Good afternoon, everyone. My name's Hassan. I'm a radiation oncologist in Calgary, and I'm very privileged on behalf of a collaborative group from across the country, acknowledging our weakness in Atlantic Canada and the hope for that to grow, to talk about a project that bore out initially. Thanks. Much better. I was probably sitting in that corner a year ago. I got the socks, and not crew socks, dress socks this year, and it kind of stimulated my idea and my thought process, and I was really inspired by work from members including Cynthia Maynard at SHRM in Montreal about challenging paradigms to do better for our patients, trying to look at things in a slightly different lens and to find opportunities. We're really asking one question. If we can see a lesion that is theoretically underperforming in standard of care treatment, do we have the opportunity to identify that and then in turn rescue? About 1,000 to 2,000 Canadians are diagnosed with gastrointestinal NETs each year. And in those with metastatic well-differentiated disease, lutetium dotatate therapy is one of the best systemic therapy options that we have. But for many patients, they progress on that therapy, and it only partially works. And so when it fails, there are actually few validated options left. I've sat in clinic and have been referred and asked, can you deliver radiotherapy, external beam radiotherapy at that, to this patient who has gone through PRRT and has a dominant lesion that has not responded? That's driving their progression. What do we do about that, and can we rewind and step in a bit earlier? Here's some of the evidence. We know from NETTER that lutetium dotatate improves progression-free survival, but not overall survival. A 30% response rate means that there are a reasonable proportion of patients who are getting an incomplete response. Why is that? We know from work including members of the group of this trial that there's a relationship between mean absorbed dose and outcomes. Our group has shown that that absorbed dose per administrative activity correlates with treatment response. There's also data from a group in Montpellier in France that have shown that a cumulative mean dose of under 52 gray correlates with overall survival. So, while there are many factors that can drive an individual's progression, as the bias of a radiation oncologist, we know from external beam evidence that lesional dose may be associated with improved outcomes, both local control and potentially overall survival. We have lesion A here. It's strongly somatostatin receptor positive. PRRT works here. There may be another lesion where cumulative dose or intracycle dose seems to be suboptimal. We don't routinely measure that, but if we could we then rescue it? Perhaps this is a group or a lesion that is driving that patient's progression. We can see it on imaging, we can measure how much radiation it gets. If we do that consistently, can we then employ a mechanism to rescue it, to intervene in real time before it drives progression? That's the gap that we're trying to close. Theranostics is powerful, and it's most powerful when we use all of its ability, from imaging through to selecting patients, but then guiding personalized treatment. We're not quite there yet, and we're hoping that we can establish and better understand that as the first next step to guide personalized treatment. Firstly, looking at pre-treatment imaging. If dual tracer PET can identify lesions that will be undertreated, can we then in turn use post-cycle SPECT dosimetry to quantify exactly how much each lesion gets? And if so, and we're able to predict that a lesion is undertreated, can we rescue it before that one drives progression? We would then endeavor to use an intracycle external beam stereotactic radiotherapy boost that is both precise and accurate, delivering a high dose per lesion to drive control there and prevent progression. Again, these are questions. We don't have answers, but I think this is a forum where we're trying to challenge conceptions and trying to move the needle forward. This is that same patient from before, but things have changed. Same heterogeneity. We're complementary actually in these two presentations. We know that there's heterogeneity within a patient, but now we have a plan, or at least a thought of a plan. We can identify a lesion that has low dose uptake, delivering an intracycle external beam boost between cycles 2 and 3, And what we're asking is, can we do this feasibly? Can we do this safely and across multiple centers? Because if we can, the implications may be significant. We may be able to challenge our conceptions and paradigm. Our eventual hope, again, this is a first step, is to create and run a randomized control trial. This is a single-arm feasibility study. We're asking, can we develop a workflow to then in turn test a hypothesis? All patients in both arms, but in this current proposal, receive standard of care lutetium dotatate treatment. All will undergo 2 time-point post-cycle spectrosimetry after each cycle. And then after cycles 1 and 2, if a lesion is seen to be underdosed, theoretically, at less than 50 gray, we flag it. We then assess whether or not we can deliver an external beam boost, a maximum of 5 lesions, and delivering within an 8-week intercycle interval. Our primary aim is ambitious, but relatively straightforward. Can we identify a theoretically undertreated lesion and then develop and deliver protocol-compliant external beam radiotherapy? We're not simply asking, can we do this? We're asking many more questions. We're collecting dosimetry records and lesion-level response data. We're trying to generate evidence and workflow that then has a knock-on effect for all the evidence that well may follow. Our study also includes a significant translational piece. We're trying to understand if there's a mechanistic synergy between these 2 modalities. We have low-dose radioligand therapy and high-dose perfraction external beam radiotherapy. We want to better understand if there's an immune response and if radiotherapy can trigger that, external beam radiotherapy, pardon me. Feasibility and strategy are somewhat orthogonal. We're going to develop this protocol and learn on the go. We understand that, and there's a lot of Pandora's box in this situation where we need to ask the questions, learn as we develop a protocol. Why are we taking this approach? Again, I said feasibility and strategy are somewhat orthogonal, but from the outset, why 50 gray? This isn't arbitrary, I mentioned it earlier, but it's exploratory. Existing evidence has shown that there's underperformance of lesions that don't get this level of dose per treatment. Why after cycle 2 are we using an intercalated window? We know that early in a treatment course, immune cells are better preserved, and we know that we have an 8-week window. Earlier cycles deliver more effective dose, and we still have time for further PRRT. Why stereotactic ablative radiotherapy? Why add in external beam radiotherapy? We've seen and we know that high local control rates with external beam radiotherapy, when it's used as a monotherapy and combined with radioligand therapy. And we know from existing data, largely retrospective, that when you combine modalities, there's lower recurrence rate in the treated lesions with external beam radiotherapy and acceptable toxicity. This isn't trivial. We understand that. And combining high-dose external beam radiotherapy and low-dose internal radionucleotide therapy isn't trivial. Dose rate differ on the orders of magnitude. So our solution, by working with industry partners and Ascenta Technologies, is to develop a personalized radiobiological dose accumulation model that's in turn validated and utilized with a centralized QA platform across centers. We want to develop to learn and to create a consistent validated workflow that ensures that a patient, regardless of where they're treated, has the same path. That's one reason that having an across Canada multidisciplinary collaborative approach matters. We're leveraging expertise from key stakeholders and key knowledge holders. This is the first step. It's opening that box in a deliberately staged research program. As I mentioned, our hope is that we can create a randomized control trial, but we need to create a validated and safe feasible plan. We're looking for safety data, a dosimetry record, and an immune data set that currently doesn't exist. It's this infrastructure that we build that will have a knock-on effect and positions Canada as a leader in personalized radiotheranostics. We have a team that spans almost across Canada, from Vancouver, Calgary, Montreal, and Toronto, treating patients, both in English and French, really combining clinical, research, and industry, because this collaboration is what the problem demands. Just in wrap up, precision radiotheranostics for this circumstance is ideal. We have a group of patients who have few options when PRRT fails. Can we step in earlier? The question is, can we have a validated workflow of seeing and treating before that lesion drives progression? This is a 10-patient feasibility study. It's small in comparison, but it's a necessary question for us to ask to change the paradigm. Thank you.